Good morning, good afternoon, everybody. Welcome to this satellite session. I'm so happy to have you all. My name is Judy Hanyola, and we will continue with our session as people continue to join us. It's for me, it's 4 p.m. in my time. And it's time for the session to begin. So once more, I welcome all of you, heartily welcome you this afternoon, this morning, for those of you on the western side of the hemisphere. For those of us in Africa, it's late afternoon, early evening, and wherever you are around the world, welcome to this Global Nursing and Midwifery Leadership satellite session that AFREHealth has done in conjunction with CUGH as part of CUGH 2021. We have a wonderful array, as you can see those beautiful faces on the screen in front of you, to talk to us a little bit about nursing and midwifery leadership, looking at both sides of the world, the global north and the global south. And we'll spend the next 3 hours or so deliberating on key issues that affect us as nurses. I will begin by introducing myself. My name is Judy Hanyola. I am the chair for the Center for Nursing and Midwifery at the University of Global Health Equity in Rwanda, and involved in educating nurses and midwives in this part of the world. I would like to just take a few moments to talk a little bit about housekeeping for this session. As you all come in, you'll be muted. Kindly use the chat box to comment and ask any questions. We have currently, as per the conference organizers, they informed me yesterday that we had 86 registrants. I don't know if all of them will join us today, but because we'll be so many, we kindly ask you to keep your mics on mute as much as possible to avoid disruptions as the session is going on, and request you to post your messages or your comments on the chat. I would also add that if you could just give a quick introduction of yourself as you post your question, it would be very helpful so that we know who you are and the context within which you are coming from. I would just like to take a few moments to introduce the agenda for this afternoon. We have 3 hours. We will do our best to keep time for the next 3 hours, and we are going to start just with the introductions that I have. We will then move on to a really exciting first part of our program, which will be an interview with these lovely ladies that you see in front of you, being interviewed by a health journalist by the name of Edem Tokono from Ghana, who will be interviewing these 5 ladies, and I will introduce them in due course. We will also have a quick brief on AFREHealth, which is the sponsor for this satellite session and what it's doing in Africa. And this will be done by none other than the president, who is also a nurse and a midwife, Associate Professor Abigail Kazembe, and she'll take us through a quick brief on what is AFREHealth, what we are doing so far, where we are. And then after that, we will have the interview. It should take about 120 minutes to go through that. And then from there, we're going to go into 3 breakaway sessions. The breakaway sessions are divided into, the first session is on advanced practice nursing in Africa. The second session is on North-South, South-North collaborations. And the third session is on nurses at global decision-making tables. You are free to select whichever session interests you that you'd like to join once that breakaway session comes around, and have further discussions within those breakaways on pertinent issues in those particular topics. And then at the end of that, we will come together to just give a quick wrap up of what was discussed, what are some of the recommendations that came out of your discussions, and the way forward. So colleagues, without further ado, I would like to hand over to Abigail Kazembe. Abigail is the president of AFREHealth. She's a nurse midwife, and she'll talk to us a little bit about herself, talk to us a little bit about AFREHealth. Thank you so much, colleagues. Welcome, welcome, welcome. Lovely to have you all. Please feel free, speak out, talk. We really want to hash out things around nursing and midwifery. This is a perfect platform for us to do that. Abigail, over to you.
Thank you so much, Judy, for that introduction. Good morning, good afternoon, or good evening. Welcome to this interesting session about nursing leadership, nursing and midwifery leadership. Before we go into details, I would like to share with you briefly about what AFREHealth is all about.
So you can share your screen, Abigail. Priska, stop sharing so that Abigail can share. Thank you.
Okay, I just did.
Thank you.
Okay. AFREHealth simply stands for the African Forum for Research and Education in Health. And what is it? This is an interdisciplinary health professional grouping that works with ministries of health, training institutions, and other stakeholders to improve the quality of healthcare in Africa through research, education, and capacity building. It is a conglomerate of individuals, institutions, associations, and networks across the geographic and linguistic regions of Africa. You are aware of the different languages that we have in Africa, and we are trying to capture all that in the association. How did AFREHealth come into being? A little bit of a background. It was established in August 2016, but registered in Ghana in November 2017. AFREHealth is based at, the Secretariat is based at the Kwame Nkrumah University of Science and Technology in Kumasi, Ghana. It is an independent body that emerged from the Medical Education Partnership Initiative, MEPI, and Nursing Education Partnership Initiative, NEPI. Both MEPI and NEPI were funded by PEPFAR, NIH, from 2010 to 2015. So as you can see, the period phased out. Now, where were these NEPI and MEPI locations? For the NEPI locations, I must say we are privileged today. We have our PI, Susan Michael Strasser. She worked in 6 different countries with about 22 schools of nursing. And the locations for the NEPI institutions are in DRC, Ethiopia, Lesotho, Malawi, Zambia, and South Africa. MEPI locations were in 12 countries and they had about 13 schools. They had 12 PIs on the MEPI program in the following countries: Ghana, Nigeria, Kenya, Uganda, Tanzania, Botswana, Zimbabwe, Ethiopia, Mozambique, Malawi, South Africa, and Zambia. AFREHealth was set up to institutionalize and sustain achievements that were obtained through the MEPI and NEPI. It was such a good program that after it had expired in 2015, there was a general feeling that we should not lose the gains. Instead, work out a mechanism on how we are going to maintain or sustain the gains that we had acquired from these 2 programs. So sustainability was a concern. Currently, AFREHealth has over 60 schools of medicine and nursing Africa-wide. And we also have global partners that are either working with us or supporting us in various forms, or we have different understandings that we go about. These are just a few of the partners that we have. PEPFAR, CUGH is our big brother, HELSA, HW21, UCSF, and Kwame Nkrumah University of Science and Technology, and of course, NIH and ITI. These are some of just a few of our partners. And we enjoy working with the different partners as an association, because each partner brings in something that the association is benefiting from. And in terms of governance, AFREHealth is governed by council members who are from different health professions across Africa. As Judy said, I am the current president from Malawi, a nurse midwife by profession, and the vice president is Professor Elsie Kiguli Malwade, and membership is open to all individuals as well as institutions. And you can download membership forms on this website. So you are free to join at any time. What is our vision and mission? Our vision statement is that we are a responsive health workforce for providing relevant, high-quality, evidence-based healthcare in Africa. And our mission is to provide African leadership for responsive health professions, education, training, research, and service in order to contribute addressing key health priorities that include HIV and AIDS, TB, malaria, maternal and child health, non-communicable diseases, and emerging diseases and repeat epidemics and pandemics, including COVID-19. So as you can see, this is basically what we are doing. We network with the different professions within Africa and across abroad. This is why we exist, and we are so privileged today to learn more about nursing and midwifery leadership in Africa. Thank you. Hello?
Yes,
I don't
Abigail.
know, were you able to hear the presentation?
Yes.
Yes.
Yes,
Okay.
we heard you. Thank you. Well done.
That was a brief introduction. I'm done. Thank you.
Thank you very much, Abigail. And without further ado, I would like to hand over to Eden Tokono, and she is going to interview our global nursing leaders. Before she does that, I will just take a few minutes to let you know who it is that you're going to be listening to. And I won't, you forgive me, leaders, that if I was to start reading their CVs, it'd probably take more than the 3 hours we've been allocated this afternoon. So I'm just going to give a very quick brief of each and every one of them, and I will do this just by alphabetically. I will start with Dr. Bola Ofi, just to give a quick brief of who she is and what she has been doing in the field of nursing in these last years. So Dr. Bola Ofi is an RN, RM, a BSc nursing, MSc with a PhD in educational management. And she has infinite work experience working as a nursing officer at the Royal Infirmary in Dundee, Scotland, and as well as the University Teaching Hospital in Ibadan, Nigeria. She's also worked at the College of Nursing in Oyo State National Health Institute, and as well as the School of Nursing in Gaborone, Botswana. She's also a lecturer in the Department of Nursing at the University of Ibadan from 1983 until 2010. And she currently is the pioneer head of department in a new Department of Nursing in the College of Medicine, Lagos State University, as well as holding the title of the chairman for the Nursing and Midwifery Council of Nigeria. She has had many publications in peer-reviewed journals, a membership of several associations, among them the West African College of Nursing, Sigma Theta Tau, and the Nigerian Association of Nurses and Midwives. She's received several awards, Senate research grants, and various others. She has taught both at the undergraduate, postgraduate, and fellowship level for many years and supervised many masters and PhD candidates, and is currently doing the same on a part-time basis. She has provided sterling leadership for university departments for many years as head and collaborated with others in multidisciplinary research for health promotion in the area of maternal, child health, and cardiovascular events. So that is Dr. Bola Ofi. Our second panelist is Bongi Sibanda. Bongi is from Zimbabwe as well as the UK. She's an alumni of the International Council of Nurses, nurse practitioner, Anglophone Advanced Practice Nursing Coalition, and is an international advanced practice leader with expertise in health policy and interprofessional international education. She currently works as the lead educator for advanced clinical practice in Epsom and St. Helier at the NHS Trust in London, where she's responsible for the organization's educational policy, strategy, and clinical supervision for multiple professional advanced practitioners. Bongi is also a core team member of AFREHealth, representing family nurse practitioners in the Africa region. She also serves as a member of the International Nursing Recruitment Advisory Group for NHS England and is its Global Influencer Advisory member, as well as being a member of Sigma Theta Tau International, the Nursing Honor Society. Bongi is a dual qualified as an emergency nurse practitioner, as well as an advanced nurse practitioner in primary care. And her current research focuses on advanced clinical practice supervision. Bongi was one of the first 4 advanced nurse practice leaders to be awarded the American Association of Nurse Practitioners internationally for advancing advanced practice nursing in low and middle income countries. I will then talk about Jemima. Jemima is from Ghana, and she's an RN, RM, MSc, PhD, fellow of the West African College of Nursing, and is a multi-skilled midwife and nurse with over 31 years experience locally and international in public service, doing independent consultancies and development work in health system strengthening, maternal health, midwifery, nursing programs, projects management, administration, and research. She has held various leadership positions and has led teams both locally and internationally, serving with the UN. Most specifically, she has served as a regional midwives advisor for Anglophone Africa for ICM on a transcontinental program in collaboration with UNFPA and provided technical backstopping to UNFPA midwifery programs in 10 countries in Africa for the last 5 years. She served on the ICM board of directors for 6 years and also led efforts to establish the Ghana College of Nurses and Midwives, a specialist postgraduate fellowship college, and served as its first president and first acting rector, as well as established 10 postgraduate programs over almost 6 years. She has also served in the capacity of international maternal health midwife consultant for UNFPA Sierra Leone, where she's led collaborative efforts to develop and launch the first ever strategic plan in midwifery and nursing, as well as a policy for clinical competency building, preceptorship for the Ministry of Health and Sanitation, among many other efforts. In 2020, recently, she supported the ministry and UNFPA to document the evolution of midwifery from pre-war situation to present day in Sierra Leone. Dr. Dennis Antwi Jemima is currently the President and Chief Executive Officer for the Center for Health Development and Research, which is an NGO with a goal for health workforce capacity building and advocacy. Her long-standing interests include sustaining health workforce, education in delivering and designing cutting-edge initiatives. Sheila Tlu is known to many of us, and Sheila is a professor from Botswana. She has just made Advance Media's list of 100 most influential women in Africa. Yay, Sheila. She's the co-chair of the Global HIV Prevention Coalition and the co-chair of the Nursing Now Global Campaign. From 2010 to 2017, she was the director of UNAIDS Regional Support Team for East and Southern Africa and is a former member of Parliament and Minister of Health of the Republic of Botswana from 2004 to 2009. She is also a former professor of nursing at the University of Botswana and director of the WHO Collaborating Center for Nursing and Midwifery Development. She has conducted research, taught courses to nursing, pre-medical, social science students on race, ethnic, and gender issues relating to HIV/AIDS and sexual and reproductive health and rights. She played a key role in the development of nursing and medical education curricula to broaden the scope of health sciences education in Botswana and the SADC region. Working with young people, Professor Clow was the HIV/AIDS coordinator at the University of Botswana, where she facilitated the formation of the Students Against AIDS Society and is a co-founder of the Society of Women and AIDS in Africa. She holds a PhD in public health nursing from the University of Illinois at Chicago and has many publications on ethnic and gender issues related to HIV and AIDS, sexual and reproductive health and rights, and community-based approaches to HIV prevention. During her time as the Minister of Health, she contributed to the improvement of global healthcare in various ways. She has received more than 30 international awards, among them the Botswana Presidential Order of Honor, the President's Award from the U.S. National Academy of Nursing, the President's Award from the U.S. League for Nursing, the Princess Award from Thailand, and the Christian Raymond Award from the International Council of Nurses, as well as the Princess Muna Al Hussein Award from the American Nurses Credentialing Center. This is Sheila, and this is just a very short summary of her achievements. And last but not least, we have Susan Michael Strasser. Dr. Strasser is an associate professor and a public health professional with over 25 years experience in nursing and public health. She is currently the Senior Director for Human Resources for Health, providing leadership, guidance, and direction for the development, implementation, and assessment of programs in human resources for health across ICAP at Columbia University's portfolio of programs. This work focuses on improving acute and chronic health care, as well as the management and mitigation of disease outbreaks. She is the PI for CDC and HRSA-funded program in DRC Congo, South Africa, South Sudan, Sierra Leone, and Zambia. She has served at senior management and training levels at various locations throughout Southern Africa, and her areas of expertise include pediatric care and support, nurse training, and the use of point-of-care diagnostics. She's a pediatric nurse practitioner, a member of the Sigma Theta Tau Honor Society for Nurses, a member of the Associations of Nurses in AIDS Care, and a fellow of the American Academy of Nursing. Dr. Strasser holds an MPH and MSc in nursing from Yale University and a PhD in public health from the University of Cape Town. You've seen how long it's taken me to read this CV, so this is a very illustrious panel, good people, and we are here this afternoon to listen to them, to hear from them, to ask them questions, and over to you, Edem, for this wonderful interview. Thank you.
Thank you very much, Judy. I am so honored to be asking these illustrious women these questions, and I'm excited to hear what their responses are going to be. So we'll just get started. I'd like to start with Professor Sheila Tlu. Professor Sheila, with the ever-changing healthcare landscape, nurses and midwives are constantly faced with new challenges, practices, and opportunities. And so based on this scenario, in your opinion, what are the main challenges facing nursing and midwifery policy today? And what do we need to do to solve these challenges?
All right, thank you very much. And let me greet everybody who is here participating with us. And I'm hoping that I know we will have a great afternoon. And thank you very much, Judy, for that eloquent introduction. The question said, in your opinion. So let me simply say that it's not my opinion. It's what I have observed, having led the Nursing Now campaign for a whole year, for more than a year up to now. I'll start first with the very Nursing Now campaign itself to say, as far as I'm concerned, what has it done? I will say, firstly, it brought nurses together around a common agenda throughout the world. And not only that, we actually were able to get people who are non-nurses, people from other professions, not even health professionals, to be able to participate and actually support nurses in that campaign. Now, the timing of the Nursing Now campaign came in just before the major challenge of the COVID-19 pandemic. And yes, it started well. We were able to mobilize, we were able to do advocacy with the World Health Assembly to the point where the 2020 was declared the year of the nurse and the midwife. And indeed, with the Nursing Now and the Nightingale Challenge, we were able to actually now have young nurse leaders, so that I can say, okay, now we have future leaders who have been trained in leadership, mentored throughout the world. Now, for me, the most important thing has been that the governments have been able to recognize nurses and midwives for the great, formidable, and compassionate force that they are, a force that can take care of humanity in all aspects of life, be it at community level, at clinic level, or even at a hospital level and at ICU level, especially now as we're talking about the COVID-19 pandemic. So that it really now highlights for me the challenges. The major challenge has been, as I'm seeing, has been research, on the very challenges that we are experiencing. Therefore, I feel as nurses, now that we are united in the world and we know each other, we need to do more collaborative research on what we can be able to do. So that collaborative research is very important, collaborative research among nurses themselves. But guess what? Collaborative research with other health professions. You cannot imagine the disappointment I'm having that now we, countries throughout the world are discovering, coming up with COVID-19 vaccines. But Africa, with 54 countries, we have not been able to do anything. Would there not have been a group of scientists, health scientists, to come together with other scientists and nurses included, to be able to say, let's come up with something for ourselves, and with nurses' input, to even be able to say, when we now are injecting this, is it better to do it intramuscular on the, on the arm, or on the thigh, or what? So what I'm simply saying is that we need to now unite in the training, unite in the education, and unite in research. And I'm really glad, happy that we had a presentation before us, the AFREHealth presentation. Let's unite under that and see how we can be able to collaborate in research among ourselves, but also with other healthcare professionals. CUGH is a great one. It would now be meaning collaboration even outside of Africa. But let's start, charity begins at home. Let's do the home one first and really look at how we can use our regional economic communities, such as SADC, such as East African Community, and in fact strengthen Hexacon and the West and Central Africa community to ensure that Africa as a whole, we collaborate even more. We can be therefore become that formidable force. So I think the last one I want to touch on is really you're talking policy development. Now, what I've seen, the challenge in policy development has been that we did not really have nurses at that high level where policies are made. Some of us, for example, when I was Minister of Health, I was able to resuscitate, reinstall the position of the Chief Nursing Officer. But as we have progressed, we are seeing where the position of Chief Nursing Officer needs to be strengthened even further. Right here in Botswana and in other countries as I've been visiting, I'm seeing that, yes, because of the Nursing Now campaign, a lot of countries have reinstated that, or actually started it, the chief nursing officer, but have not given that office the power to be able to do anything. In fact, sometimes the chief nursing officer position is lower than the other directors. So that it becomes therefore a challenge in that the policies are made in the absence of this one person, and he or she is told later to say, oh yeah, it has been decided this. That will not do. So we therefore need to unite to be able to say we need that position to be very strong so that that person can be at the decision-making table. Because let's face it, if you are not at the table, you are on the menu. And indeed, we are seeing exactly that, where despite the Nursing Now campaign, we are still having to struggle in terms of policies that really augur well for nurses and midwives. So let me stop right there. Thank you very much.
Thank you very much, Professor Sheila. Thank you so much. I'll move on to Bongi right now. Bongi, advanced nursing practice is relatively new in many developing countries, especially in Africa. So what is the meaning of advanced nursing practice? What are the roles of an advanced nursing practitioner, nurse, or an ANP nurse or midwife? And is there a difference between ANP and specialist nurse? If so, what are the differences?
Thank you very much, Adam. Greetings, colleagues, wherever you are. And thank you, Judy, for that great introduction. Yes, to answer your question, Adam, first, I would like to say AP and advanced practice nursing is not new in Africa. In fact, it has been there for decades. So Prof. Lowe, who has just been speaking, was instrumental in driving the CNS role, which has seen us reduce the number of HIV transmission and the progress made in AIDS and antiretroviral therapy. And in fact, Botswana has more than 4 decades of leading the region with family nurse practitioners. In the development of family nurse practitioners and serving our primary care populations. So to go to the definition, really, I would prefer that we stick to the definition that is outlined by the International Council of Nurses. So the International Council of Nurses released the guidelines, the updated guidelines last year, 2020, and the guidelines focus on the 2 roles of advanced practice, and that is the nurse practitioner and the CNS role, which is the clinical nurse specialist role. But I'll go later into detail why that those 2 roles only do not work for us in Africa. So an advanced nurse practitioner, an advanced practice nurse, is a master's level trained professional who has been trained beyond the generic nurse training with expertise on clinical focus to make complex decisions, and has acquired those competencies as well to drive change. Most importantly about the definition really of advanced practice nursing is that context is key. So where this person is credentialed in every in the country is key to the definition. So the difference then between a nurse practitioner and a CNS. Again, I'll go back to the guidelines that are actually available on the internet, but I'm happy to send a link as well later on the chat box for everyone to the APN guidelines, the ICN ones. It actually clearly stipulates the difference between a nurse practitioner and a CNS. And this difference is based on the 4 pillars of advanced practice that we look at when we are training someone to be an advanced nurse practitioner, to see at the end of their, whether it's a 2-year or 3-year master's program or doctoral program, to ensure they've achieved these pillars. So these pillars, the most important one, the most one that really tends to be reflected is the clinical practice pillar, that is direct patient care. Then you've got the research pillar, research/innovation, that really looks at research publications, driving innovations and service delivery. Then you've got the leadership and management pillar, so it looks really, the different types of leadership and advancing others, as well as improving health outcomes. But under the leadership and management pillar, you also have the policy that Prof. Lowe was talking about, which is key in advanced practice, because it's important that an advanced practitioner is skilled in really influencing policy. Last but not least, you have the education pillar. As advanced practitioners, we have a responsibility to ensure that we develop not only ourselves, but the future generation as well as other healthcare professionals. So that is, in an nutshell, the definition of advanced practice and where it sits. And then to go back to why I was saying the two definitions outlined in the ICNAPN 2020 don't work very well for us in Africa, is because as we know, and I'm sure we'll hear this from Dr. Jemima, who is on the call today as well, advanced practice midwifery is critical, not only global, but more so in Africa, where we have one of the highest maternal and neonatal mortalities. So our advanced practice midwives are key in driving policy in those areas, are key in educating other healthcare professionals, and as well as providing direct care to women and their families as well. Then we have also the nurse anesthetist in Africa. That sort of really correlates to our colleagues in the US, in Northern America, where they've got those four different levels of advanced practice. So our nurse anesthetists really play a key role, and we have seen this really, and we have seen this in the countries such as Liberia, where they are the main key practitioners providing anesthesia at district and rural level. And the International Federation of Nurse Anesthetists has worked very, very closely with countries such as Liberia and Kenya. So we have those two extra pillars, extra specialists in Africa that are very key in driving excellency and key in helping us achieve universal health coverage. The nurse anesthetist, the advanced practice midwife, the nurse practitioner, and the CNS all play a key role.
Thank you so much, Bongi. Thank you. And you've led us into the question for Dr. Jemima, which is that as the SDG Goal 3, which is good health and well-being, focuses its two targets on the health of mothers, babies, and young children. Target 3.1 aims to reduce the global maternal mortality ratio to fewer than 70 per 100,000 births, while target 3.2 aims for neonatal mortality to be fewer than 12 per 1,000 live births, and under 5 mortality to be fewer than 25 per 1,000 births. So at a global platform, what role could midwifery play to influence human resources for health policy, to ensure equitable and quality health services, to reduce maternal, neonatal, and infant mortality in the sub-Saharan region?
Thank you very much, Adam, for the question, and hello to you all. Warm greetings from Ghana. And thank you very much, Judy, for the kind introduction. It's exciting to be part of this important panel and to share with colleagues. Let me start by saying that maternal health and child health, as we all are aware, and by the 5-year strategic plan of the WHO Nurse and Midwifery Directorate, shows that it is of high priority. And this dates as far back as the MDG era, when we realized that mothers and their newborns were being wiped off because there was virtually very few midwives to address the maternal health needs in most of our countries. Midwifery was getting extinct. Over the years, evidence has proven that with a qualified, well-educated, well-resourced midwife, over 50 health outcomes related to maternal and child health can be improved. And therefore, mothers and their newborns can survive they can thrive and they can transform their lives into responsible adults and contribute their quota to national development. Human resources for health policies are therefore critical to guide production and deployment of midwives for qualified and equitable distribution towards the quality services that we crave for. In this era of SDGs and universal health access by 2030, midwifery has a critical role to play at the table of global health, and also as we sit at the table of higher level advocacy. And to do so, advocacy is key in everything that we ought to do. The advocacy should center around showing the evidence that midwives and midwifery does create impact in maternal and newborn health. And I think that our voices need to be heard louder. There is also the need for global leadership and resource allocation. And I'm glad that Professor Tulu indicated that at the table of decision making, most often at that higher level, nursing and midwifery may not necessarily be represented at that table of discussion. And that is why it is important that at the global level, midwives are given a voice to advocate and continually press home the need for more midwives in order that we can increase access to care. Global leadership and resource allocation needs to look at the adequate production of qualified numbers of midwives. It needs to look at equitably deploying these midwives guided by staffing norms with emphasis on how to reach communities for universal and affordable access. For most of us who have worked in developing countries, we tend to realize that as you go into these countries, you find our midwives in the cities and in the main towns. Whereas when you go to the hard to reach areas, you are likely not finding them there because of the lack of enabling environment that must exist in order that midwives can be retained and they can provide the services they need to communities. There is therefore the need for human resource policies at country level. We need to drive country-based strategies, and I'm glad that for most countries that I've had the opportunity to interact with, they have human resource policies as general policies for the Ministry of Health. However, when you go in to look at the nitty-gritties of the specific health professionals, you realize that there are generalities but very scanty information on midwifery. And therefore, it is difficult to note how many midwives actually do the countries need over which specific period of time. Is there any midwifery workforce mapping that has been carried out to know how many we have now, how many we project to have in the next 5 years, and what distribution system we have put in place in order to track their postings in order to make sure that they are also able to work adequately and effectively. There's also the issue around how to retain these midwives, even when they are placed within the communities to serve. Most are under-resourced, either forgotten, or the ability for them to receive continuing education is compromised, therefore undermining the competency that they need in order that they continue to practice. There is also the issue of giving the opportunity for midwife-led services, where midwives as autonomous health professionals are able to drive their initiative, lead in midwifery care, because we all know that over 70% of women can actually be supported to deliver without medical intervention. What they need is the support of a kind, respectful midwife who is there to walk them through the pre-pregnancy stage, pregnancy, labor, post-partum, and then also to meet their needs, their reproductive health needs as women. And therefore, as we look at pushing the agenda of SDGs 2030, we need to look at favorable human resource policies that would ensure that the midwife is where she should be, supported, encouraged, and well educated and resourced in order that we can save the mothers and the newborn. Thank you very much.
Thank you so much, Dr. Jemima. You are leading us into the next question for Dr. Bola, which is, in sub-Saharan Africa, nurses and midwife roles and responsibilities have been transformed to embrace functions or services previously considered the purview of doctors, such as safe male circumcision, vacuum extraction deliveries, and HIV services, just to mention a few. So based on this scenario, what regulatory mechanisms could nursing and midwifery employ for the attainment of global health? Dr. Bola.
Thank you very much. Can you hear me?
Yes,
yes, we can. Yes, we can.
Thank you. Thank you very much for inviting me for this pre-conference of the consortium of the universities in global health. I'd like to appreciate everybody. I'd like to appreciate the organizers of the program. And I say good afternoon to everyone on the platform, co-presenters that have just presented, and greetings from Nigeria. From the question about the changes in the role of the nurses and midwife, I would like to capture it under the issue of expanded role. And first and foremost, I'd like to say that the issue of expanded role in nursing and midwifery had been for a long time. It had been since the time of our mother, Florence Nightingale, because if not, she wouldn't have been classified as being part of the rudiments of statistics in healthcare delivery. So the issue of expanded role had always been there, as I said, and there are reasons for expanding roles of professionals within a multidisciplinary profession, or like healthcare delivery as we have. We have examples in Botswana during the HIV/AIDS, when the need to distribute drugs to people in the rural area was a challenge, and there was need to train others in healthcare delivery apart from nurses, doctors, and so on and so forth, in order to meet that particular need. We'll also realize that the issue of expanded role can be identified when there are some sort of shortage of manpower, particular manpower, that can result into tax sharing, as we have currently in many developing countries. We have tax sharing between doctors and nurses, and so on and so forth. So really, the issue of us taking on, nurses and midwives taking on roles that are previously jealously guided by other professionals in healthcare delivery has come to stay. And it is worth noting that the professional boundary lines are getting thinner and thinner by the day. But what would be, I mean, what do we need to do in nursing and midwifery to ensure that this expanded role and these new roles that had been bestowed on us, either because of shortage or because of urgent need in healthcare delivery at the particular point in time, what we need to do is to ensure that for us to take on any expanded role, there must be adequate training. The training can be part and parcel of the ongoing curriculum so that the nurses that are coming out in the future already have the competencies. And also training, continuous training through mandatory professional training, professional development, or ongoing training right through workshops and seminars to ensure that the competencies that are required for that new role is achieved. Because for us to take on a new role, you must perform the role the same way, at the same level of competency as the original owners of the role. For example, as has been earlier mentioned, we had the program on LSS, life-saving skill is called, life-saving skill, in Nigeria and in many West African countries in the early 20s, early 2000, early 2000, to empower the midwives, because it was observed that the maternal mortality at rural level was much greater than at in the urban centers. And by so doing, the midwives needed to be trained with competencies to do vacuum extraction, to do episiotomy and suture episiotomy, to give oxytocin intravenously, to set up lines, and so on and so forth. And this was a training given by international agencies right through the country to ensure that maternal mortality and infant mortality is greatly reduced. Through the expanded knowledge, competencies of midwives, especially those ones that are working in the rural areas. And it has, from the data has shown great improvement and great reduction in maternal mortality. And of course, there was the issue of the anti-shock garment that midwives were trained to use. And, you know, so many things. But what I'm driving at is the fact that the competencies must be there through training, proper training, not just on the job training, but real education, going through school, adding it to our curriculum, giving it in mandatory professional development, and so on and so forth. All the ongoing trainings that we have in our various settings. Of course, the focus on global health at the moment is on the Sustainable Development Goals and also the universal coverage of health. And how can regulatory bodies ensure that these trainings are given and at the same time you have legal backing to forestall order, especially in our healthcare delivery in Nigeria and in most of African countries in which there is rancor and conflict among health professionals because of professional arrogance at times, because of lack of understanding of what's going on in other professions. And we need to identify through monitoring the trends, the scenarios, like ICN had said, to be able to identify, to be able to identify areas of need of the various health systems. It is true, health is global. Yes, the regulatory bodies usually monitor what goes on globally. But at the same time, they monitor what's going on nationally in order to ensure best practices in the country within the context of the health system in which they are functioning. So for us to be able to ensure that the global health is maintained within the context of this expanded expanded role, the regulatory bodies must ensure that the curriculum is reviewed regularly and new inputs, new findings, new areas of need are added on to the curriculum at various levels, whether at nursing level or at the midwifery level. And of course, ensuring also that the competencies that are to be displayed are achieved during that particular training. Regulatory bodies also need to collaborate with international agencies, like for example, WHO. WHO is always telling us where we should strengthen midwifery, where we should strengthen nursing through the various assemblies that are held nationally every year in Geneva. And of course, the International Council of Nursing is the big umbrella over us, and as such, we also need to monitor what ICN is saying, what ICN is doing. I'd like to mention the futuristic nurse project that was done, and the paper, the documentation that was put out in 1999 to 2020 to intimate nurses with the fact that for us to be futuristic, for us to identify our preferred future, we need to monitor the larger society. We need to monitor globally the health trends, the society at large, and the trends in nursing as well, for us to be able to say, these are the challenges, these are the things that are happening, but this is where nursing wants to be in 2020, and this is where midwifery should be in 2020, without anybody imposing any policy on us, but for nursing to identify by itself, this is the way forward, this is where we are going, this is our preferred future for 2020, 2021, or even 2030, which is the year for the end of the Sustainable Development Goal. So the regulatory bodies really need to be futuristic. They need to expand their scope, collaborate nationally and internationally, and bring to bear to each country what they can do and adapt, cope with within best practices, but at the same time domesticated within the country. And I'd like to give an example of what had just happened in Nigeria not long within the last 1-2 years, in which some states were identified to be fueling the maternal mortality and the infant mortality, and the council, the National Midwifery Council, now established a program of community midwives and community nurses, a short course of about 2 years, train the people. They come from the locality. They are in the locality. They are employed by the locality, so that there is continuous skilled personnel in the various states. It's not all the states that have adopted it, but the states that were really in need of such program. And
thank you.
I would like to stop here,
Yeah.
and thank you very much for the opportunity.
Thank you, Dr. Bola. Thank you so much. Earlier on, when Professor Sheila was speaking, she mentioned the need for some collaboration amongst African nurses, but also amongst nurses and midwives on the continent and then outside the continent. So I'd like to ask Dr. Susan, what in your view is the best North-South or South-North collaboration scenario, and what do you consider to be the key ingredients for a successful North-South collaboration?
Great, thank you for that question, and thank you to Judy and all of the organizers. Can you hear me okay?
Yes, we can.
Absolutely, absolutely.
We can hear you.
Great, okay, good. I think the way that I would like to respond to your question is built on my own experience, and I think Judy and I have really cultivated the relationship that I think is what is needed. It is a truly an equal relationship, a North-South collaboration that is based on mutual respect. That is, it has a deep recognition of what the other person brings to the table. And I think having lived
Oh dear.
We lost you. What happened?
Oh dear.
Dr. Susan?
Yeah, we lost you.
We lost you, Susan. She's
I think
back.
she's back, yes.
Okay.
Okay, I'm going to put on the audio from my phone. I think the network is a bit unstable. If you can hear me okay,
Yes,
just give me a thumbs up.
Yeah.
Okay,
Yes.
great. Yes, so what I was saying is I think it is one that's based on mutual respect and a deep understanding what the other person brings to the table. Judy and I have worked closely together and really cultivated that equals relationship. And I think having worked and lived for so many years in Africa, I bring a perspective knowing that the North has many things to learn from the South, that the North, the attitude that has prevailed for so many years, centuries, is that we are bringing something to help change and improve the South is very outdated.
Oh dear.
You're breaking again.
Oh dear. Susan, perhaps you can switch off your video. Oh dear.
She's frozen.
Yeah, her connection is unstable.
Oh, she's back.
She's back. Sorry, Susan. We can't hear you.
No audio.
We can't hear you.
Oh dear.
Can you hear me now?
Yes.
Yes.
Perfect. I'm going to use my phone, then we won't have a problem. I'm sorry. So the North-South collaboration has to be developed on mutual respect and trust, learning from each other what we can do.
Susan, do you have your two devices open at the same time?
Yeah, is it going? Okay.
You don't have to go off.
You have to mute. No, you have to mute your computer.
Yeah, mute the second one.
The computer.
Can you also ask her to switch off the video, please?
Yeah.
Hello.
Okay, I'm just going to go with my internet without the video. My apologies.
Okay.
So my apologies for the interruption. So I think there has to be, in addition to mutual respect, I think there has to be a genuine interest in what the other brings to the table, the other's experience. And I think that has been enabled in me through living and working abroad for so many years. And we need to get out of
It looks like we lost her again, right? Am I the only one?
No, not only you. Same here.
She's having challenges. Just maybe in the interest of time, and once she's back, we can give her an opportunity to speak, because she's speaking something that's really critical for us in this discussion.
Yeah.
It's 6 minutes past the hour, and we still have time for this lovely discussion, and extremely happy to all of you wonderful nursing leaders, Sheila, Bola, Bongi, Susan, and Jemima, for your insights. Adam, do you have other questions to ask them? There's so much information they still need to give us. Yes, please go ahead.
So,
yes.
Okay, so I'll go back to Professor Sheila to ask, I hope Professor Sheila is still, yes, still here. So today's healthcare leaders are continuously facing challenges to meet high expectations and adapt to change. So at a global stage. Oh, yes, Susan, you're back.
Yes, okay, I just have a few more points. I'm going to move.
Okay.
I'm sorry, I'm in a very big building and I don't know why there's such challenges. I think this is a good example of the North having to learn from other places. The connection for some reason is very unstable today. When I think I lost you is learning from the other and really appreciating what the North does well, but what the South brings as well, and that we don't get blindsided or fooled to think that the North, with technology, with the great infrastructure, with research institutions, has it all figured out. Because from a health and a public health point of view, COVID has shown that that is not everything, and there is much more to health than universal. And I think the South has so much to teach the North, and the North has things to bring as well. And the things I want to point out that I think the North needs to learn from the South are the role, the importance of deep community engagement in building healthcare and healthy populations, the ability to do task shifting at scale. And I was really happy to hear my other colleagues say that advanced practice nursing has been happening for hundreds of years in Africa, and that this is nothing new, that task sharing is not new, and that it is nursing, and that nursing in Africa
Susan, your connection is really... So sorry, Susan. You cut out a little
Judy.
bit. No, it's fine.
It's frustrating. Can you hear me now?
Going in and out, but we can hear you now. Just power through, Susan. It's okay. We're nurses. We are used to this.
It's really frustrating. To a different connection, which should be stronger. Okay. So my final point, I'm not sure where I finished up, but I'll just reiterate that I think the North learning from the South, and the South providing its expertise where necessary in a mutually collaborative way is what is needed. And that includes, from the South, deep community engagement, task shifting, and using a public health approach. The North has a tremendous amount to learn from these three areas. And I'll say it again: deep community engagement, task shifting, and a public health approach. The North, I think, has much to share as well, but also with the understanding that there are weaknesses within the North health system, and that we cannot have an illusion that because we have tall buildings and high-tech infrastructure that we have it all worked out, because COVID has clearly shown we don't. We have 500,000 deaths in the United States from COVID, despite the great infrastructure. But I do think the North does have much to share as far as nursing research, nursing informatics, and the use of data, the use of health policies and research. Thank you. And I'm really sorry about all this connection. I've moved down to another office space and this is should be much better. My apologies.
No worries,
Okay.
Susan. Thank you.
Thank you very much, Susan. So in the interest of time, we'd just like to ask, I'd like to ask for all your final remarks, parting words, advice, comments, feedback. We'll start in the order that we started the Q&A. So Professor Sheila.
Yes, thank you very much. I think for me, the parting ways, I want to answer the second question.
Okay.
As to where I feel nurses they can be able to be to participate, especially in what would you say, in local organizations.
At a global stage.
At the global space, locally
yes,
and
yes.
globally.
Yes.
I want to start with local because I think local is more. I usually say, look, let's start with the basic and then we can move further. At local level, we need nurses in the political space. I know when some of us were in nursing and were being taught the characteristics of a profession, we were told that it is apolitical. Now that killed a lot of nurses because they really didn't understand that apolitical meant you do not align yourself with any one political party. But indeed, everything that we do is political. We vote, we whatever. So I think, some of you who are still teaching professionalism to your nurses, please clarify that. It simply means you don't go around saying, I'm UDC, I'm UDC. But in there, to make sure that everything that is a challenge in the country, you participate as nurses and give your views. So for me, that really happened a long time ago. And Tari will tell you that for HIV, I was an advocate, right from the epidemic when it started. And I would actually go to the president and say to him, you are not doing enough for the country. So that's why, for me, I think being made a minister was really to say, come and say what the hell you have been saying we're not doing. But, put nicely to say, come and help me with the AIDS response. Now, being there, I know a lot happened because a lot of things, especially at country level, happened maybe because there was a nurse who knew what nurses could do in the absence of medical doctors. And I'll tell you just the statistics of why I'm saying nurses need to be right there at the political level, whether as a member of parliament or as a minister, even as a councillor. We had councillors in Botswana who were mayors, and their cities were the best. Now, when I left, after 4 years of being a minister, working with nurses and midwives and everybody else, and including nurses who were at the WHO, because I had asked WHO to say, when you hire locally, make sure that you hire my nurses. I will not accuse you of poaching. You'll be helping me because I'll be knowing, and some of them are my students, they know what my views are, and we were able to work together, such that when I left, we had brought down mother-to-child transmission from 29% to 8%. Maternal mortality due to HIV was down 30%, and in fact, our maternal mortality rate was 107 per 100,000. Infant mortality rate was 17 per 1,000, and under 5 mortality rate was 32. Guess what happened when I left and they put medical doctors and they stopped that collaboration and really making sure that the nurses are well engaged. As I'm talking to you now, from the last year's State of the Nation address by our president, infant mortality rate is now 36. At 17, I brought it closer to the SDG level. It's now double, it's 36. Maternal mortality, under 5 mortality rate is now 58. I left it at 34, very close to the SDG level. So that shows you that when a nurse leads and involves other nurses and midwives and all those advanced practice nurses, a lot happens. So I simply want to, that's my parting way to say, encourage your student nurses to say, politics is dirty, but somebody has to do it for the nation. So thank you so much. Yes.
Thank you. Thank you, Professor Sheila. Okay. Bongi, what are your parting words for us, please?
Oh, thank you. Oh, what an amazing conversation we have had so far. And I would like really to stress on the importance of collaboration that has come up and again. That is so key, collaboration and interprofessional education, working across industries and across organizational for us to drive outcomes really, not only in advanced practice, but in nursing and midwifery at a broader level. So I would like to start locally. So locally within our own countries, we need to be able to connect with our MPs. And as Prof. Sheila just said, I don't know how many of us as nurses have actually reached out to our member of parliament and asked them,
Please go on, Bongi.
Mute your microphone, please, if you are not speaking. Thank you.
Sure. Thank you. Yes, so reaching out to our members of parliament, reaching out to our councillors to really find out how we can drive policy, how we can drive changes at local level, reaching out to our government chief nurses to understand our work and the projects we are doing. And at a regional level, I really want to go back as well to the area of leadership, collaborating on leadership. And John Maxwell's quote that I really love to quote when it comes to leadership, that everything falls and rises with leadership. We need to have coordinated approach as a region in Africa. I would like to stress again and again the need for us to have a chief nurse at the WHO at regional level to help influence change, to help us put the recommendations from the State of the World Nursing Report to drive regional global directions for nursing and midwifery. And then I also think about in advanced practice in terms of who do we need to collaborate on as advanced practice educators, as advanced practice leaders. Our organizations in Africa, the AFREHealth, the Africa Interprofessional Education, our colleges, the Hexagon and the WACNI. Then if you look at a broader level internationally, so how are we working with the International Council of Nurses Advanced Practice Network, other colleagues such as the American Association of Nurse Practitioners or the Association of Advanced Practice Educators in the UK. So we need to really think strategically, and as our colleague earlier on mentioned, this need of really looking up to the North for everything. At times we need to question it. We need to question our reliance on westernized curricula that is not fit for purpose within African context. So I'll drive back into ensuring that we actually make sure that our advanced practice programs are context specific and address the needs of our population as we look at collaborating, and I'll say collaborate and advance practice. Thank you.
Thank you very, very much for those words, Bongi. Dr. Jemima, any final words for us, please?
Yes, thank you very much. Interesting discussions. I would like to pitch my discussion also at the level of educational reforms. I must say that since the early 2000s, there has been massive educational reforms so far as midwifery is concerned on the African continent. Through the initiative of WHO, International Confederation of Midwives, and then also UNFPA, we have, through the Investing in Midwives program, we've had a lot of countries in Africa. I would like to say that our 18 Anglophone African countries as part of ICM and 16 Francophone countries have all been part of a driving initiative towards educational reforms, where countries have had the opportunity to engage with needs assessment studies, looking at establishing new midwifery schools, looking at raising the qualification, the qualifying qualification from mere certificate holders and community midwives now to have diploma level, bachelor's, master's, and PhD programs. Now we have countries like Ghana, Malawi, Ethiopia, Uganda, running higher level education programs in midwifery, which hitherto never existed. We have curricula that have been revised, reviewed, developed to reflect this higher level of qualification. And we have massive regulatory strengthening programs that are based on the ICM International Confederation of Midwives Global Standards. Educational reforms have been uptaken looking at the ICM Global Standards of Education. And we have these emerging leaders who can now feed into faculty and who can then also feed into various levels of leadership. Now, the issue is around positioning our colleagues at the right place at the right time in order to be able to project the voice of the nurse and the midwife. And that most often is the issue. Most often we are siloed into either the education sector or the clinical sector. So you are either teaching or you are at the bedside. And that leaves most of our colleagues out of research, out of advocacy, out of the myriad opportunities that exist in reproductive health. And then also being at the table of global leadership. Most often, you tend to see our colleague doctors filling up all these positions, whilst we are not able to enter because most of these positions are clipped for us. And I think that this is where we need to be able to look at mentoring our colleagues to be able to move beyond their status quo, move beyond their comfort zones, to begin to occupy or attempt these positions. These positions don't come by easy. They are difficult positions because you actually need to sacrifice a lot. But I believe that if we are able to rechannel ourselves into these positions, then just as Prof. Sheila said, we can begin to then rally our colleagues at the national level, regional level, and international level to begin to position strategically and to make our voices heard across the globe. So we need to begin to look at building our forces on the ground and positioning them regionally and internationally to be able to be the advocates for the profession. And then also looking at continuing education. Now, the power of continuing education through online systems has been born with the advent of through COVID-19. Now we are here gathered over 50 people from across the globe. That shows that continuing education can be pushed ahead, can be forged ahead, and we can bring global leaders together to share experiences. And I believe that educational reforms are key, and we need to move ahead with this. Thank you.
Thank you very, very much, Dr. Jemima. I was making notes as we were talking about the educational reforms. Dr. Bola, any parting words, please?
Thank you very much. It's been very, very interesting and very stimulating to listening to other colleagues. One thing bogs my mind, and it is our position in WHO. Right now, I'm really not sure whether the nurse's position that used to be there in the past, a representative of nursing, that is a position, a seat, or what would I call it, that used to be there in the past is still the same as today. Professor Clow may be able to clarify that area for those who are very familiar with WHO, because I realized, or I remember in the past, that position, that nursing position was cancelled, and the position was open to anyone, believing that it's an administrative position and it didn't be specifically for a particular profession. Because if we are having challenges at WHO about nursing position, then we need to start where, we need to straighten up at the top so that it can disseminate down into the various countries and so on and so forth. As others have said, the issue of collaboration is key between North Pole and South Pole, between developed nations and developing nations. Definitely, as far as I'm concerned, I don't think there's a lot of problems in the developed nations like the UK, like the US. The professionals seem to work together. They seem to embrace multidisciplinary and team approach in a sort of a manner that the population is in the center and everyone is contributing to the health of the population. Whereas in our own Africa, there is still this hierarchical structure in which our medical colleagues want us to believe that they are the leaders and all other professionals in healthcare team are below them. But unfortunately, it has never worked. It has always been conflict, it has always been rancor, and so on and so forth. And our healthcare, let me say specifically in Nigeria, is not as healthy as it should be because of interprofessional conflict amongst us. So there's need for a lot of collaboration within the health professionals themselves, collaboration with the non-governmental organizations who are doing a lot of work in education, in practice, and so on and so forth. And of course, in research, we are lagging behind. We are totally lagging behind in research amongst ourselves, amongst nurses, midwives, within country, cross countries, and internationally. A few research grants are given at university levels and so on and so forth, but we need more in community studies rather than just in an educational setting for promotion and so on and so forth. And the bone of the whole thing is our position in governance. Where are we in governance? Is there a nurse governor? Is there a nurse president? Is there a nurse, minister and parliamentarian senators? A few here and there, but definitely we need to enter into politics in such a manner that is benefiting healthcare and is benefiting the various professions, not partisan politics like we have in Africa at the moment, where the whole thing is hulu balu, shouting, yelling, and so on and so forth, but in a professional type of manner. How do we do this? We need some training. We need training in political process and in policy processes. I don't know how the US achieved theirs, where a nurse is always in parliament, appointed, whether appointed or elected, I'm not sure, but there's always someone there. From the time of Clinton, from the time of President Clinton, they established that position and it's been maintained ever since. There is need for us to also achieve such position in Nigeria. We are large enough. In Africa, look at the number of nurses and midwives compared to other professionals. In number, in intellect, at the moment, we have professors, we have PhD holders, we have gone beyond, we have progressed educationally. There is no doubt about that. There's no doubt about that. We have definitely, all we need to do now is to make impact by getting into governance through political process, through lobbying, through collaboration, and of course, through doing research in healthcare to showcase what we can and what we can do. Thank you very much.
Thank you very, very much, Dr. Bola. And finally, Dr. Susan.
The connection. Thank you.
Yes.
And I just want to thank all of the other speakers for their comments. I'm I'm so happy to be part of a group of very strong and dynamic nursing leaders who are really trying to push health forward and push nursing forward. I think I just want to build on what the other speakers said and what Sheila said about politics. Health is political. Health is deeply political. Healthcare and who is healthy and who is not is deeply political. We've seen that very starkly in the United States in many ways with the rising of maternal mortality amongst segments of the population, primarily African American women, having much higher rates than white women. We've seen great disparities between those who are getting COVID-19 in the US and those who are dying from COVID-19. The social determinants of health are very serious and profound, and that makes health very political. And so I agree, Dr. Bola, we have to be engaged in politics. And I think in the United States, there has been a great deal of progress, but there are still many challenges. And Martha, one of the colleagues here in the US, pointed out recent pushback by the American Medical Association against advanced practice registered nurses. So we inherently have this tension because there is money, prestige, positions, a piece of the pie involved in nurses taking on advanced practice. But as you said, and others have said, nurses have always been in advanced practice, and it's important that nurses are in advanced practice to drive health forward. But we have to continue to be in the political space to push against any resistance to change or any resistance to having nurses at the table, which we know is pervasive at the WHO, at regional levels. So I think really pushing ourselves to engage more and more politically, and I think Sheila has really charted the course in that regard for us. One of the final things I want to say around politics is being engaged in pushing the World Health agenda forward. And there is push right now for the World Health Assembly to put forward better health protection safeguards for health workers. And we've seen the protection of health workers through Ebola, through HIV, through and COVID now, that health workers need greater protection. And the one that needs the most protection, because the one that is most likely to die, is the nurse, because the nurse is present, the nurse is at the bedside, the nurse is providing that intimacy of care. So there's going to be put forward a resolution at the World Health Assembly this year, and I'm trying to get another country involved in seconding that motion. But please join me in pushing for better protection for health workers as a political agenda for all of us to work toward, especially in light of COVID-19 and all that it has unpacked around the vulnerability and the absolute essential role of nurses. Thank you, Judy and Idem, for the great discussions.
Thank you very much. Thank you so much, Dr. Susan. I think my big learning from this has come at the end, which is that health is political, whether one would like to admit it or not, or whether one has realized it or not. So I'm going to hand it over to Judy now to close out the session.
Thank you so much. That was such an interesting conversation. And I think for me, since COVID began and we've all been pushed back into working sort of in isolation, these discussions are very important to keep right front and center so that we don't forget the importance of talking with one another and hearing each other. And I'm very grateful for this collaboration between CUGH and AFREHealth to provide the platform, and for the 50 plus of you who have been with us thus far. Don't go home yet. We still have a few more minutes just to, I think, talk more and talk deeper. I would like to just give a background really around the AFREHealth Governing Council. Again, just like all you speakers have said very correctly, there's a tension between the doctors and the nurses. Within the Governing Council, which is the highest decision-making organ of AFREHealth, we only have just 7 nurses, of which I am one, Abigail, Priska, Tabi, Victoria and Funmi, Rose and Rogate are part of, and that's why we came together to sort of just beat the drums for nursing, because sometimes it can get subsumed. And like you are all saying correctly, health is political, and a lot of these tables are political, and it's an old boys club type of thing, where if, you know, we don't keep on bringing ourselves forward, people forget and our agenda is lost, like you've all said correctly. So having said that, we'll take a few minutes. I don't want to take up too much time. I know we have the full 3 hours. We don't really have to go through the full 3 hours, but I would like us to go into breakout rooms. I am going to assign that. I hope I can do this well. There are 3 breakout rooms on advanced nursing practice, on global collaborations, and on nurses and midwives at decision-making tables. This assignment is, what is it, voluntary. Just choose the one you are interested in. I'll open out all the rooms. We can take a few minutes to just talk in depth and come out with a few recommendations way forward. So this conversation doesn't end with this particular satellite, but that we keep moving agendas forward, like Susan is saying, taking things to the highest decision-making tables so that we actually see a difference. And oftentimes, as nurses, we forget that we need to be well ourselves as nurses to give the care to the patients. You can't give what you don't have. And these meetings and these discussions also look towards ensuring that our well-being is taken care of. When we hear the tensions between physicians and nurses, it has an effect on us, sometimes physically, sometimes, oftentimes emotionally. So we need to take care of ourselves. So I'd like that we have tangible outcomes, not just talking, but something tangible that's helpful to the nurse. And when the nurse is well, we know definitely the patient is going to be well. So I'm opening out all the rooms. Yes, Priska.
Before we go to the rooms, when are we going to take questions?
Yes, I forgot that in my rush for time. Please, Priska, can I hand that over to you? You've been managing questions. Absolutely.
Okay, thank you very much. Before we go into our various breakout sessions, actually, I'm here with my colleague, Professor Ntabi, who we are managing the questions together. And I want to say it's been a fantastic, incredible session. I've learned quite a lot myself, and I'm so happy having all these incredible women. And it's wonderful that we just had International Women's Day yesterday or so. So to have all women affairs today is fantastic. Kudos to the great women in the house. The questions are not many because they've been interacting amongst themselves. Some questions have been directed to some of the panel members, and the panel members have actually gone ahead to answer questions. There's only a man. There's only one man who has been feminized. This man has been feminized. So
welcome, Funmi. Welcome, Funmi. Yes.
Okay, so I have a question. I'm going to take the first question from Busisiv Bengu from South Africa. And her question, she directed us to page 17 of the ICN guideline, where she's talking about a category between a general nurse and clinical nurse specialist. And she is interested in finding out if someone can expand on that for her. What does that mean in that ICN guideline, particularly on page 17, where there is a categorical difference between a general nurse and a clinical nurse specialist? She just wants a kind of explanation on that. And she didn't direct to anybody, so anyone could actually pick that up for her. Thank you.
Bongi, probably that would be you. Tell us a bit about those differences. Is Bongi still with us?
I think she left.
Yeah, she left.
She sent a message that she was going to leave.
Yes, that's right. Who wants to take a stab of this? Yeah.
She said on page 17 of the ICN guideline that there's a categorical difference between a general nurse and a clinical nurse specialist, and they call that specialized nurse. So she wants to know if someone can expand or expatiate a bit on that for her.
If we are looking at the concept of general nurse and clinical nurse specialist, a clinical nurse specialist is like someone who has done a master's program in advanced nurse practitioner program, or in any midwifery community, and so on and so forth. So a clinical nurse specialist is someone that has special skills, special competencies in that specific specialty area, like midwifery, like community, like critical care, and so on and so forth. But a generalist, a general nurse is one that probably has a degree, a Bachelor of Nursing Science, which is the beginning of the professional entry into nursing in many, many countries, including even Nigeria. But a clinical nurse specialist is like a consultant, haven't done specialist program like what you have among the doctors.
I would also want to, if that is so, in terms of the specialist programs. If we look at our structure in nursing and midwifery, we have the basic education where you do it. Currently, we have it either at the certificate level, diploma level, or bachelor's level, depending on the country and its educational system. So if you take, for example, my country, Ghana, currently, those who do basic nursing or midwifery are categorized into diploma or first degree programs, depending on your entry qualification and into which institution that you enter. And then, of course, we have the auxiliary program as well, which is certificate level. Now, if you look at entering into after your first degree, you could go into to do your master's and to do your PhD. However, in our country, before you can be considered as a specialist professional, you have to enter the Ghana College of Nurses and Midwives. And this is a specialist institution backed by an act of government that allows our cadre to progress to specialist level. And this is synonymous to the Ghana College of Physicians and Surgeons, the Ghana College of Pharmacists, and then also we have the allied health professionals also towing that line. For you to enter into the specialist program, you must have at least your first degree in nursing or midwifery, and you choose a program of interest to you. That is the minimum post-qualification experience should be 3 years. You have to be released by your institution to undertake the course because it's full-time, and the course is for 3 years. It's purely professional and recognized and regulated by the Nursing and Midwifery Council, which sits on the board of the institution. When you graduate from the specialist college, you are recognized by government as holding a membership position with the Ghana College of Nurses and Midwives, and also as a specialist professional in clinical care. And your position is even above the Deputy Director of Nursing Services in terms of remuneration. So it's a very high position when you are able to go through the specialist course. And then, of course, you can move into your fellowship, and then before you can consider yourself into a consultancy position. So these are, let's say, progress in education that we have currently. And I know that other West African...
Thank you very much. Thank you very much. I invite my colleague to take the next question. Professor Ntabi, over to you.
Thank you, Priska, and good evening to our great presenters who have learned a lot. We continue to learn. There was a question about how to connect from, this was for Bongi, but I think it can be answered, but in terms of, I think there's interest in advanced practice, that how do we connect students, advanced nurses students to do clinical hours
your network is not very good.
Wow.
Okay, the network is poor.
How do we connect with
Tabi, your connection is really dragging.
And then there were also, oh, my network is not good. Oh,
Yeah,
I'm telling you. I was saying the question. Oh dear. Can you hear me now?
Now, yes.
Okay, I was saying there was a question about how to connect nursing students, I believe, from the north to the African continent to learn to do their clinical experience and learn about African nursing models. And then the other questions came about whether or not we have jobs for advanced practice nurses who choose to return to the continent, and if there are any additional education certification requirements per each country.
Thank you. That question is from Lizette Kimbere, who is a doctorally prepared oncology nurse practitioner and practices in New York. And she teaches advanced practice nurses as well. So any of the panelists can assist in answering that question. I hope we got the question from Tabi. Okay, did you get the question that she was trying to ask? So any of the panel members can assist us to answer it. She wants to know how possible to learn from Africa and how nursing students can be connected between the North and South so that they can learn about African model of nursing. Anybody?
Yeah, I'm happy to contribute.
Thank you.
I believe that it's purely a collaboration and a partnership. And again, it will depend at the level at which this partnership must be established. You could look at establishing it as an inter-university partnership where you identify an African nursing or midwifery institution, and then your organization also and then you link up and come up with a partnership agreement and begin to look at exchange programs. I think a lot of countries do this. University of Michigan, for example, has a lot of collaborative programs in selected African countries. It can also be done at the level of association to association, where, let's say, American College of Nurse Midwives or American College of Advanced Practitioners would also want to join up with a professional group and use that as a medium of exchange and support to learn from each other. And then also you can look at regulatory body interlinkages or partnership, where again, you could use through regulatory bodies to study, because if you enter through the regulatory body, you also have access to all the institutions of nursing and midwifery for you to learn from. So I think it can be done at various levels. It only takes, let's say, a few people to sit together and say we can drive this partnership, and then begin to do the collaborative discussions, involve stakeholder engagements, and then based on consensus building, begin to put things on paper and draft partnership agreements. I think that if you choose this pathway, you should be able to reach somewhere.
Thank you very much.
Also, there is this type of linkages are already ongoing in various universities. University linkages for exchange programs between students at various levels of their education. For example, in some institutions, nursing students are allowed to have some exchange program in some UK hospitals that the university programs are situated in. University of Ibadan, for example, we've had linkages with University of Pennsylvania for so many years for staff and student exchange. But as the economy dwindled in various countries, many programs have been reduced. In the costing is now becoming more of the African countries being able to afford a bit of the cost, whereas in the past, University of Pennsylvania would pay all the costs for us to go to their university, for our students to go to their university, both for boarding, airfares, and so on and so forth. But it's a global economy. And of course, it's even worse right now with the situation. So we are looking forward to COVID going away so that we can continue where we left off in 2019 when the COVID pandemic started. But definitely all that she has described can be arranged between institution in the developing nation and institution in the developed nations, as it is already ongoing right now. Thank you very much.
Thank you very much. I don't know how much more time we have, but we have 3 more questions. This question is from Georgina Yeboah, who is the Executive Director of AFREHealth. She said, is there an issue with the training at the pre-service education level where nurses and midwives are made to think that they are only for service delivery? What is wrong with that and how can we fix it? I hope you got the question that Georgina Yeboah is asking. Thank you. Susan, you want to take a go at that? No, okay, I saw you nodding.
I think partly there's so much to learn in the pre-service training at the basic level, so much emphasis on getting through all of the curriculum across mental health, midwifery, psychiatric nursing, pediatrics. I think it's very full, and we deprioritize those other elements, which I think are as important. And I think looking at how we continue to emphasize those is an ongoing challenge.
Thank you. The second part of that question, which has not been answered, is thank you so much for that brilliant contribution, is how do we fix this? Because we cannot continue to produce people who are going to have an utopian understanding of what they want to do, and the system in which they find themselves is different. Is there a need to do something differently? What exactly can we do to fix this? Yes, over to you, Jemima.
Yes, I think that for every professional career, we have what we call the basics. You must have the basics and then you build on it. So within the nursing profession and the midwifery profession, I think we have been able to come this far where if you have your diploma, it is basic, because at the level of diploma, it is the basic preparation to which you can build upon yourself. Because you cannot stand anywhere with a diploma and say you are, you can represent the highest qualification of your profession. So that sort of limits you in terms of the opportunities that can be availed to you. But as you add more value to yourself, the opportunities expand. And I think that the challenge that we have now is to be able to create the windows of opportunity for our colleagues to see that as you study and move higher, you don't necessarily have to be either in the classroom alone or at the bedside alone. And that there are so many opportunities out there that you can branch onto and continue to be in the profession and add value to the profession. Unfortunately, we have had instances where as our colleagues move on to higher ground, they leave the profession. So you have nurses who have started out with their basic degrees, have gone on to a master's, probably branch into law, and then they are lost to the profession. Some have branched into research, they are lost to the profession. Others have branched into communications and all that. How can we stay in the profession and still add value to the profession? Because that is the only way those who are coming up will see that, oh, I can be a nurse and also be a lawyer and be an advocate for nurses who get into trouble with the law. I can be a midwife and be involved with well woman care and provide specialist midwife-led model of care for reproductive health services and still be a midwife without leaving the purview of the profession. I think that this is the way that maybe looking to the future, we need to begin to build ourselves and connect with each other to support the younger generation to diversify themselves. But at the basic level of pre-service, there is surely a level to which you can go. Thank you.
Thank you so much. Now I'm happy. Okay, Dr. Bola,
one question, ma. Is it not about time we streamline our profession into an entry to the entry qualification that is comparable with other health professionals in the same system? For example, for you to be a doctor, a pharmacist, a physiotherapist, a dentist, and so on and so forth, you must have a first degree. So it's about time. Nursing says the only entry qualification into the profession is the first degree. And I think US is already towing that line, and no sooner than now, I'm sure, the colleges, the associate programs may have to be brought together into university profession, and making sure that the first degree is what is required as entry into the profession. And that would make the professionals not think the way the person who has asked the question about why some are in service, some are here, some are there. That's a question for us a food for thought. Thank you.
Okay, thank you very much. There's a question from the panelist member. So another panel member to answer. Susan, raise up your hand.
Just briefly, this is a challenge we've had in the US for many, many years. And based on the economy and interest in the nursing profession, it has vacillated back and forth between a strong push for the entry level to be at the bachelor's level, to drawing back to having 2-year associate degrees in nursing. And currently we do have 2-year entry level nursing programs, which I think many women and men come out of and have very successful careers, but being encouraged to then complete their bachelor's degree with their employer. So it's a constant tension between interest in the profession and the demands for the number of healthcare workers, but I think it's a laudable goal.
Thank you. Jemima, raise your hand. Thank you.
Yes, thank you very much, Susan, for this. And maybe to put another twist to it, I would say that this is very political. I say it is political because a lot of African governments, of course, fueled by the medical profession, do not see why nurses and midwives should be operating at all nurses and midwives should be operating at higher degrees. The argument, and I know that we have Georgina on board, who is a human resource specialist. The argument has been that if you look at the numbers of nurses and midwives in every country, we have formed over 60% of the population. If everybody is going to start at the qualification of a first degree, the country cannot afford to pay. So they use this as a political twist and ensure that there is always a minimum level of qualification. But I think that the challenge again comes back to us, for us to make sure that we add value to ourselves. Because the more nurses and midwives who add value to themselves, governments can no more ignore. So though you may start from a mid-level of a diploma, you know that once you have a diploma and universities recognize your diploma qualification and allows you to add value to yourself, you should explore, take advantage, and use that as the platform to go beyond the sky. And for me, I think that this is where, again, the mentoring comes in. Thank you.
Thank you very much. I invite my colleague to ask the last question.
Yes, thank you, Priska. There's a question, given what you just said, Susan, we want to find out, there was a question from Pandora about what the American Nurses Association is doing about this hierarchy. And I would also go further to say, having worked in the African countries that you worked in during the NEPI period, which areas really stood out to you that you think they need to be strengthened the most if we are to achieve universal health coverage by 2030? Thank you.
Those are big questions. I think under the experience I had with NEPI, working with the Judy, what struck out most was, I think, what you have all been talking about, that sort of imbalance between the absolute essential role of nurses in delivering all aspects of the healthcare system, from primary health care, preventive medicine, curative care, soup to nuts. Nurses are doing it, and the overall lack of investment in nursing education, and the infrastructure, and the lack of adequate supportive supervision and mentorship during their clinical rotations. I think, given the role of nurses in driving healthcare throughout Africa, they are the primary provider, and the educational systems should reflect that. I think one of the things that we tried, I think successfully through NEPI, was to really enhance preceptor education and training, because that's really where the theory practice divide is reduced. Investing in preceptors and also in simulation-based education, which I think helps nurses to gain greater comfort and gain expert skill in many aspects of work. And so we continue to work in the area of simulation in Sierra Leone, really building up robust simulation programs for nurses. So I think investment in nursing based on my NEPI is still needed. And nursing needs to be seen as not an economic loss to a country, but actually one of its greatest resources to drive healthcare and a healthy population. And I think as nurses, we need to use our voice to push that. Yes. I'm not deeply engaged with the American Nurses Association, although I do know them. Most of my work is more global. They do have very active lobbying at the state level, at the federal level. So there is very intensive political engagement. I think there could be more. We saw this past year with COVID-19, the absolutely appalling response during the past year of disregarding mask use and all of the basics of just good primary health care. And I think nurses weren't at the table as much as I would have liked to seen them. I really would have liked to seen a nurse on the COVID-19 task force, and I would hope ANA is continuing to push for that. I think there is a lot to do, and I think we need to get better at quantifying the enormous role that nurses play in healthcare delivery, how much of the burden of healthcare is actually given by nurses, and what the benefits of that are. And I know, like, the World Bank are trying to capture that better, but this is an area we really need to get more sophisticated at, bringing the data to the table. This is what nurses do, and this is what it leads to in economic growth in the development of our societies. So 2 big questions. Thank you, Ntabi.
Thank you for answering it in a big way. You are quite appreciated. My last questions are 2 in 1. One is from the president of AFREHealth, Abigail Kazembe. She said, what is the implication for remuneration for the APNs in Africa? We have learned in Africa how specialist nurse and midwifery qualifications have been ignored. So what do we have on ground regarding remuneration for this category of workers? And very closely linked to that is another question that says, at what point should the nurses and midwives be paid for taking on extra work? I mean, we've talked about expanded role and all of this. At what point should nurses begin to demand for remuneration for taking on extra job or extra work? Those two questions are closely linked to each other, and that would be it from my end. There is a Joanna Faith Abrina, a PhD student from Philippines, who is a clinical instructor, who would like to connect with one or two of the panel members. I think she just connect with you privately, and then you keep going. Mentoring has started from there. So please, can someone just respond to these two questions in one concerning at what point should nurses and midwives be paid for taking on extra work? And what is the implication for remuneration for advanced practice nurses in Africa? Thank you.
Where is the advanced practice specialist?
I think Bongi excused herself because she said she had to go somewhere for a meeting, and she was only here for the first 1.5 hours. So yes, this would be the right question for Bongi, but Bola, you're an educator. Perhaps you can tackle this in terms of what's the point of me gaining all these qualifications if you then don't pay me at the end of it all?
Exactly.
Thank you. Thank you very much. Thank you very much. The issue for advancing in your profession, first and foremost, to me, is for self-actualization, and not necessarily because of the remuneration. But remuneration is as important as well. For us to determine at what point should we be demanding for more remuneration after taking on expanded role or extra duties will be dependent on the establishment that the individual is working in, and also the nursing association in that country. The nursing association has responsibility to ensure that nurses at various levels and higher levels are properly placed. And this requires negotiation between the Nurses Association and the Ministry of Establishment in our own country, who determines wages and upward movement of the various cadres of staff across disciplines, not necessarily just nursing. But of course, NAM, that is the National Association, has responsibility to listen to the stakeholders about poor remuneration, about non-remuneration for extra work or extra qualification. That's ongoing even in Nigeria. The midwives say they have general nursing, they have midwifery, they are practicing in a non-midwifery setting, but providing midwifery services, and still they are just being paid as general nurses. What is the why should they go for other specialty courses if they are only just going to be paid for being a general nurse? Yeah. But as I said, in thinking psychologically, first and foremost, say to yourself, I'm a midwife. I am a critical care nurse. The future is what I am looking at, and not the immediate benefit to me. When positions open for individuals to apply outside Nigeria, apply outside your setting, and so on and so forth, you already have the qualification. And it's because you are interested in that specialty. That's why you've gone for it. Even if you are not well remunerated now, you will be well remunerated in the future. But there is need for the National Association and the Directorate of Nursing at the various ministries to ensure that nurses are placed they are remunerated at whatever positions that they find themselves, and haven't acquired more degrees or more competencies or more certificates and so on and so forth. After all, within the medical structure, once you have done a fellowship, the residency that they do, they automatically become senior registrar. And of course, remuneration goes along with senior registrar, then to consultant, and so on and so forth. So there is need for us to also work out this type of structure for our nurses so that they don't feel frustrated by going to do some other courses to add value, as my colleague said, to themselves. So the National Association and the Directorate of Nursing in the ministry, federal ministry, state, or wherever, should take interest in these stakeholders' complaints and gradually lobby, work at it, politicize, speak with your parliamentarian, your whatever, in order to have your voice heard. Thank you.
Thank you very much. I'll hand over to Tabi to close the question section, the Q&A session.
Oh, okay.
You, Tabi.
I was going to add.
Oh, you wanted to say something?
Yes.
Okay, apologies.
I wanted to add, that's okay. Thank you very much. I wanted to add another dimension to what Bola said. As nurses and midwives, it is also important that we begin to look at not only the public sector to be able to enhance our career, but to begin to look at the development sector and also the private sector. So that as we add value to ourselves, especially when the value that we are adding to ourselves is not necessitated by a request from government. So for example, and our country has experienced something like that. If you decide that you want to go and do a master's and you have successfully gone through the program, you have your master's qualification. Government says that I have not informed you that I wanted a master's qualification to be on the ward. And therefore, yes, your qualification is complimentary. However, it is not a request that I have made, and therefore I cannot pay you because you've gone to do a master's. However, if you are in the service and you are given a steady leave to go and engage in any program, and you come back on graduation, the likelihood that you'll be recognized for the position for an upgrading is there. But if you look at the numbers of nurses and midwives that are in the system, and everybody will have to wait to be given government approval before they have higher education, then it means that a lot of people are going to be tiptoeing at the same point. And therefore, people have taken the opportunity to add value to themselves. And I think that in so doing, as people get these opportunities, they need to begin to explore the development sector in terms of what can my qualification offer to the development sector? To what extent am I prepared to rock my boat to be able to develop my career beyond just the clinical care? And I'm not saying that everybody should leave the bedside, but definitely people will be at the bedside. We also need people to be at the other areas in order to create the impact that we are all talking about today. And that is looking beyond just the public sector to see what is over there beyond those shores. And then also what beyond the national purview, internationally, are there opportunities, for example, inter-African countries, for you to also add value or give off your value to other countries, and that also helps you to earn a better income. So I just want to add that beside public sector, look at the development sector, look at intra-country and extra-country opportunities as well. There were so many Ugandans who moved into South Sudan to help South Sudan develop systems. People have moved into Liberia, people have moved into Sierra Leone. There's so many
Thank you very much.
that are given. So let's look at that as well. Thank you.
Thank you so much. You are greatly appreciated. Our time is fast spent, and I'd just like to roll it over to Judy. I'm sorry, Ntabi, I was going to roll it over to you, but that time has been used up, and we need to round up very quickly. So Judy, over to you. Thanks.
Really, this has been such a wonderful session, and I'm very happy and encourage all of us, even within ourselves, outside of the panelists and us, to keep on talking to each other, collaborating, and talk offline and meet and email one another for these. I think these conversations to continue in a meaningful and tangible way. I'm going to open up the breakaway rooms. I am conscious that we are somehow almost coming to an end, and we have a very strict schedule of what time to finish. So it's now 15 minutes after the hour. I would like us to take about 20 minutes just within our breakaway rooms to discuss in further detail, and then we will come back to wrap up this really exciting session. So I'll open up all the rooms and just allow you to join the room that you would like. I'm doing that now. So maybe I will ask all of you to just take 3 minutes or so to give a feedback to the wider group on what you discussed. Maybe I will start with the APN team.
Now, how many minutes?
Okay.
How many minutes do we have?
3 minutes, she said.
Okay, so who is going? Is it Abigail, Rose, or myself?
I think Rose started to talk.
Yes, okay, go ahead, Rose.
Yeah, I had, thank you, Chair. Our group had 7 people, and we spent a bit of time because I was alone in the room for some time. So when they came, we started this. So we were with, it was Rose, Abigail, Bengu, Unja, Lisette, Priska, and Candace. We generated 5 questions, and because of time, we had not exhausted all of them. But one of them was challenges of placement of students in the clinical area, the APN students. And we agreed that this one we have to talk to each other because exchange student programs are quite many in almost all the universities. And we agreed that we shall contact each other so that we can establish MOUs and this one can go on. So our colleague from New York, that was the discussion. How do we ensure that people trained are well placed and remunerated? We said we have to work together, collaborate, and also do advocacy. However, when we tried to go to the 3rd question and 4th and 5th, we were time barred, so we did not discuss the rest of the questions. But the one was, how do we establish these positions in places where they do not exist? And
Rose,
what do we want?
We can ask Pandora to talk to us about that.
Yes, Pandora had actually was talking, and then we were cut off. My sister Pandora, can you tell us how we can establish?
Good day. Yeah, we had just started to talk about having to approach the APN piece through the multiple pathways. That's not just looking at the education, but also looking at some of the regulatory components that might have to be a part of pulling the rule into place, looking at the issues of scopes of practice, and also the challenges of addressing some of the very sticky issues that might be even surrounding curriculum and practice, particularly where there's low resourcing We know that we often wind up with the challenge of like, we know there's not going to be a midwife. So everything, you know, including some of the more high tech procedures, if we think about things like vacuums or whatever, are placed into the undergraduate, like diploma level curriculum. And then when we've been trying to build bachelor's or master's programs, particular in East Africa, we then had the challenge of, well, how do we prove the difference between the diploma level and the bachelor's level or the master's level? So also having to have multiple layers of the conversation surrounding not just the clinical piece as well, and some candid and honest conversations with our colleagues surrounding these issues are such complex path forward.
Thank you.
Thank you, Rose. Is that all from your team? Okay, perhaps Priska, you guys in collaboration, you are the biggest group. We'll give you the floor now.
Priska belongs.
The collaboration was in our group. I don't think.
Sorry, sorry, Ntabi.
That's fine.
Go ahead.
Victoria, do you want to go first?
Just go ahead. We don't know whether Victoria is here or not.
Okay. In our group, we came up with areas of focus that we thought were most critical. They will add. It was on leadership, that for us to raise nursing and make nursing visible, they need to be brought, to be strengthened so that they can participate in policy at policy level. And also education, the student faculty exchange, which would also bring about things like strong mentorship programs as well to inspire students and make sure that they have meaningful experiences. There was also protection of workers, so that to support nursing and midwives, or nursing and midwifery, is strengthening the health systems, which will also ultimately translate into strengthening or improving the services, and also to improve South-to-South collaboration by also tapping into the expertise that exist within the African continent or developing world itself. I believe I've covered some of these things, but my colleagues in the collaboration group will add. Thank you.
I've just added the link that Keith Martin shared, the director of CUGH, telling about the capacity building working group and also the capacity building database where universities can go and request assistance or faculty support. I think that someone else was trying to speak.
Thank you, Susan. That's very helpful, actually, in terms of collaboration. I was part of the other working group on AFREHealth and CUGH, and that capacity building working group is doing very good work around helping those who feel they need help to get faculty to help in curriculum development and various other initiatives that you may feel you need help in. And this is a very good resource for us to tap. That's a good point. Thank you, Ntabi. That was a really, I think, an interesting discussion. And for me, interesting that most people wanted to join this group because then it just shows that this collaboration is so much needed and so necessary. And I guess the way forward to work together, all of us. Last but not least, the group that was talking about how do we get to decision-making tables as nurses? Is that you, Priska?
Thank you very much.
No.
We were a group of 7 colleagues. Unfortunately, the person was supposed to take the notes from Judy, your team did not appear. So we took down a few notes, which we are happy to share. Thanks. So basically, we looked at the point around how do we, for somebody to be at the decision-making table, there must be some qualities that the person must exhibit. The quality of leadership, the quality of knowing what you're about and what your driving force is, the quality of being able to represent your profession, and the quality also of being able to think beyond the box and to contribute towards wider health professional issues other than nursing and midwifery. And therefore, it starts from the basic level of pre-service training, where we need to get our colleagues to understand that you are a leader at your basic level of posting when you graduate. So at that level, make sure that you count and you excel and you shine in that even little area. And as you do that, you build your confidence level and you begin to graduate into the leadership qualities as you move further in the career pathway in the profession. Another discussion, another area of building was to look at preparing people to be able to occupy positions so that we mentor people either through the association or through our institutions and support people to group themselves to be able to fit into certain positions so that when the vacancy arises, they can apply to occupy the position. And once you sit at that position, then automatically you are at the decision-making table. Another point that was raised again was looking at gender bias. How do we empower our people in order that they can withstand the negative narratives around gender and to be able to stand strong and to push the female gender within the healthcare setting, which is dominated by the male profession, and it is very patriarchal. How do we build our profession in order to withstand the criticisms related to gender bias and to move ahead? Then we look at policy. Policy as a whole institution of nursing and midwifery. How do we contribute to policy in such a way that policies will favor us and help to push us towards the policy decision-making table? And we believe that the associations have a big role to play. Education has a big role to play. And then also, as we sit on committees and contribute towards development of certain guidelines, we need to begin to build sort of a hidden agenda that drives our professions to be at the decision-making table. And then when we are given the opportunity, we should contribute. Most often, nurses and midwives will sit in committees and will not make a contribution or will not talk. And this more or less make us redundant at level of contribution, so that in the end, it's like, oh, even when you invite them, they will not speak, they will have nothing to contribute. So let's just get on with the business. So it is critical that we look at building our people, building their confidence, grooming them to be able to prepare themselves academically, managerially, and also administratively to be able to take up these positions when they are right. And then, of course, being political to push ourselves onto the political agenda. Thank you very much. I hope I represented my group well.
Thank you, Jemima. You did, and I actually took all those notes very rapidly as you were speaking, and thank you so much for that. I would like to bring this session to a close. We are almost coming to the top of the hour, and to just extend my warm, humble gratitude, thank you, heartfelt, to Sheila, Susan, Jemima, Bongi, Bola for your expertise, for your time, for preparing for this, for accepting the invitation, for taking the time to talk to us, for mentoring us, even as you answered these questions and as you sat with us throughout the last 3 hours. We're really grateful as AFREHealth, and we thank you so much. To the wider community, all of you who joined this afternoon, this morning, this evening, want to extend a hearty thanks. And I just want to encourage all of us as nurses as we go out to do the important unsung work that we do every single day, not to forget that what we do, I think, is one of the most important jobs in the world, despite everything that points in the opposite direction. So don't lose heart, take care of yourself, stay safe, and to just continue to ask that we continue with our collaborations, with our engagement, with our discourse and discussions, and that AFREHealth will take some of these recommendations forward and begin to see a very tangible way to implement, even if it's in a very small way. We as the AFREHealth Governing Council, nurses and midwives are going to make an effort to ensure that it doesn't end here, that we take it forward, and that everything we've discussed this afternoon begins to bear fruit. I thank you very much, colleagues. May God bless you. Be well, stay safe. And I will bring the session to a close now. Bye, everybody.
Thank you so much, Judy.
Thank you, Judy.